Let's get started. I'll go ahead and turn the webinar over to longtime AAPS member and AAPS board member, Dr. Robert Emmons, who will make a few brief introductory remarks and also introduce our main speaker. Dr. Emmons, thank you very much.
Thank you, Jeremy, again, and as always, for all your help organizing these webinars. We're announcing a new name for our webinar series tonight. We've decided to name this webinar series, The Doctors Are In. The purpose of this webinar series is to promote collegiality. Nowadays, the medical discourse is dominated by information coming from public health officials. And while that public health information may be important, it's not enough. As physicians who are practicing medicine, we need to be talking directly to each other. We need to be evaluating the science for ourselves. We need to be sharing our evaluations of the science with each other, and we need to be telling our clinical stories. So that's the purpose of this webinar, is to get us talking to each other and continuing to talk to each other. And we want this conversation to go on long after this crisis has passed. I'd also like to announce that we're starting small discussion groups. We're going to be having video conferencing discussion groups, small groups of 6 to 8 physicians and a few non-physicians. And we want to meet every other week on the weeks that alternate with this webinar. We've already got groups forming, but there's, if you'd like to join a group, there's still room, and you'll get a communication where you can express your interest in doing that. And we thank the people who've signed up already. So now it's, also before I introduce Dr. Eskew, our next topic in 2 weeks is going to be Dr. Jeffrey Dobkin, and he's going to be presenting on medical ethics, issues around medical ethics relating to population-based ethics versus individual-based ethics, and the ethics of rationing as well, issues that are brought forward by the COVID-19 pandemic. So I'd like to introduce Dr. Eskew. It's my honor and privilege to introduce Dr. Eskew. He is a friend of mine, a longtime friend of mine. He's also an AAPS board member. He's belonged to AAPS for 10 years. He's a direct primary care physician and attorney who enjoys seeing patients in multiple on-site primary care settings, including large employers and state prisons. His legal and policy research efforts have been published in many medical and legal journals. He is the Vice President of Clinical Development and General Counsel at Proactive MD. And with that introduction, of course, there's lots of more credentials, so look at his resume. I'll let Dr. Eskew get started.
Thank you, Dr. Emmons. All right, I'm going to share my screen here so everybody can see the PowerPoint slides. Okay. And this presentation was originally put together for our St. Louis meeting, which of course was canceled due to COVID-19 along with everything else this spring. And so the presentation starts by focusing on a sort of advice to your patients. And that was how I came up with the beginning of the title, which is Do Not Pay, because that's kind of the approach you should have when you get an unwanted hospital bill initially and you're trying to work your way through it. So we'll start there. We'll do some DPC policy updates, and things have been kind of quiet in the current state legislative session, so that won't take long at all. And then we'll move into some COVID-19 specific changes, which I imagine is what everybody's most interested in. So when you're advising your patient, they're going to start by demanding an itemized bill from the hospital, and they're going to move on to other things once they have that bill. They're going to audit it for accuracy. They're going to look for ways to reference fair market value elsewhere in the system. And we're going to show you some tools you can use to help your patients have those arguments. Ultimately, you can win this kind of argument in court. And I think hospitals rely on patients just not knowing how to do this and not going through these efforts. With the COVID-19 updates, we'll save those for the end. And then that'll probably be where we have most of the questions. Okay. So step number one, the patient comes in and they say to you, hey, I had this unexpected hospital bill. Can you can you help me figure out how to fight this? As my DPC physician or as my otherwise price transparent physician, I want you to help me navigate this system. So first, realize that it's probably not a bill. It's an invitation to negotiate as far as the hospital is concerned, and they're hoping that you're not going to do that. So start by not paying it and have your physician request a copy of all your medical records so that they can assist you in your audit. A lot of times if the patient asks for those directly, they may not get them as quickly, and they may not get the full set of records that the family physician is likely to get if they're the one assisting the patient. Once you get that itemized bill, you want to audit all those codes, make sure that they're actually accurate where the service is delivered. If not, you want to look into something called the False Claims Act, and that provision contains heavy damages. It was around $11,000 per claim, along with something called treble damages, meaning 3 times the amount billed. And if it's happening over and over and over, if the hospital is making this mistake systemically, then the government will go after them for quite a lot of money. If you're the one who raises your hand and says, hey, this is going on, then you get about anywhere from 5 to 15% of whatever the government takes. And some of those cases have been well north of $100 million. So if you spot fraud, you should point it out. That's not the most likely outcome, of course, but there might be any number of coding errors that you could spot or things that were done without your consent. Okay, charged amounts can be bogus, and you want to be able to point that out. And the way you point that out to the court is you find free market pricing examples. There are lots of different ways to do that. And these are just a few references out there that have ways you can quickly find prices for any number of things. If you're looking for Medicare rates, those are all public. Most people just don't know how to find them. And there's a link that you can use right there. And you can filter by your location, which Medicare uses the term MAC to describe different geographies, and see exactly what the hospital could charge and what their limiting charges are and whether it was outpatient or inpatient. So you can go in there with that as a reference too. Almost all hospitals accept Medicare, so there's an argument to be made that whatever the Medicare price was is considered a fair price by the hospital. Similarly, in many states, you can look up Medicaid rates, and here are just a couple examples, but your state should have some sort of reference you could use there too. And this is the detail. This is for your reference later. False Claims Act. Okay. And here are a couple examples of some of the larger cases. It started clear back in the 1800s when people were cheating out the Union Army. But the way it's used most commonly these days is actually in the healthcare setting, because that's one of the largest areas where the government is paying out bills. And they historically don't do as much auditing as the insurance companies do. So when they do find something, if you were the one that helped them find it, then you get a percentage of the take. And that's what they call the key TAM whistleblower provision. So again, this is there for your reference. Okay, so you want to know your opponent. There's a JAMA reference for that there. The hospital, if they litigate, they tend to not do well, especially if you're the one who brought the case first. Some do attempt to garnish wages, and we'll get into some examples here in a minute. And you want to know up front, you can kind of find out some statistics that help you decide where the pain points are for the hospital and where they might be willing to negotiate, and just how little they ultimately collect on bad debt. And that's helpful. Okay. So we'll get into those details here, and I think you'll find them surprising. So there was a group that studied several different Virginia hospitals. This was the JAMA study in the prior slide there. There's the reference. Simple 2-page article in JAMA in 2019. And they said, how many of these hospitals are ultimately trying to garnish wages, and how much are they really collecting? How much does this matter? So in 2014, broadly, 20% of US consumers had some kind of medical debt in collections. And 36% of Virginia hospitals do attempt to garnish wages, at least from time to time, but only 5 hospitals in the entire state accounted for 50% of all attempts at garnishment. The mean amount garnished was, let's see, per hospital, this is in the aggregate across all the patients they were garnishing, which was 82, was $722,000. So not much in terms of hospital revenues. It was only 0.2%. And the actual amount garnished per patient ranged from $25 clear up to $25,000, and the average was $2,700. Nonprofit hospitals were in fact more likely to garnish, which is why I prefer the term non-tax paying, because I think that more accurately reflects the fictitiousness of their nonprofit status. Okay, so wage garnishment laws, these do vary a little bit from location, but at the federal level, maximum garnishment of disposable earnings, this is worth knowing. So if a hospital's threatening to garnish the wages of your patient, you might want to hand them a resource like this and figure out how much they can actually take and whether or not the threat really has any weight to it. So that's meant to be a reference for you. If they're making less than $217 a week, then nobody's going to get to garnish anything. Additional hospital bill reduction options for low-income patients. So this is sort of another just walk through steps for you. As you get the bill, this is from Andrea Bopp Stark at the National Consumer Law Center, and she did a good job summarizing things too. So she starts out the same way I did and says, first off, don't pay it. Figure out if it's accurate. Figure out if you were eligible, you know, if the patient happened to be eligible for Medicaid, Medicare, which probably isn't the case. Figure out if the hospital is a nonprofit. You can use that to embarrass them in many ways if the patient wants to go to the press. And so this is a nice additional piece for your reference here. So I'm going to keep moving so we can get through things quickly. If you decide to head to court, this will indeed be a jury of your peers because it's made up of other patients who often do not like the same hospital that's trying to bully you around. Juries get to determine whether hospital charges are reasonable. And I have the court citation there and a quote. So I argue here that we do not have to wait for such regulation. The common law of contracts contains the tools necessary to allow courts to provide a free market solution to the balance billing problem now. That's from an attorney named George Nation, who's done lots of great work in this area and written several law review articles on the topic. So if you look at the basic elements of a contract, there's got to be mutual consent expressed by valid offer and acceptance. There needs to be adequate consideration, meaning you exchange value, one person making a promise to another. You need to have the capacity, and the entire contract, of course, needs to be legal to be enforceable. And defenses to contracts. If it was an adhesion contract, meaning a standard form contract that one party drafted and handed to another and you had no chance to go back and forth, then it's an adhesion contract and it makes it less likely that the court would enforce it. If the contract were signed under duress, then it's less likely to be enforced. And if it's unconscionable, it'd be less likely to be enforced. So unconscionable meaning nobody of any rational mind who actually read this thing would sign it and agree to these terms. So what are you thinking right now? Probably, well, if you go into an emergency room having chest pain, are you under duress? The answer is yes. If the hospital hands you a contract, did you have a chance to actually edit it and read it carefully? Probably not. It's an adhesion contract. And if it had terms in there saying you agree to pay any rate at all, it may well be unconscionable. So these are common things that would happen on a hospital admission, especially through the ER where you have the duress component. If you look at a case of the National Anesthesia Associates, this was a New York case in 2011. You had a patient who was a defendant against the hospital. He represented himself pro se, so he didn't have an attorney. He was uninsured. Hospital went after him and said, look, I don't have the money. Didn't come to trial. And there was a default judgment on liability. But later on, there was a case about how much the patient actually owed. So the first case, the hospital won, which basically says, okay, you owe us money. But there was a second case that had to be held about how much money do you owe us. The hospital wanted $8,675 for the anesthesia. And then the court said, well, you took money from Blue Cross Blue Shield for the same stuff for $5,200. And Medicare paid you $1,600 and Medicaid pays you about $800. And the court on its own wound up saying, we're not going to make him pay more than $4,200. I don't think this worked out well for him. He obviously didn't take much effort and didn't really show up to either case. But even then, when the court looked at these different prices, they wound up lowering the amount the hospital said he owed by over half. So here was some of their logic. Although plaintiff requests an award based on its uninsured patient rates, it makes no claim that any of the lesser rates mentioned are unreasonable. And where plaintiff submits nothing more than a conclusory assertion that its billing supervisor that the plaintiff's fees are customary and standard, the court concludes that plaintiff's customary and standard fees are not conclusive and binding. So the amounts actually received by medical providers from insurers are far better an indicator of the reasonable value of the provider's services than the fictitious published charges that are unilaterally set by the hospital. So a fairly logical conclusion, reasonable value is what someone normally receives for a given service in the ordinary course of its business from the community it serves. And the court goes on there. So they ultimately settled on an average charge for prices that were accepted by the hospital. California case. Howell versus Hamilton Meats held that amounts normally billed by Medicare providers are not, by medical providers are not reflective of market tested values and thus are not an accurate measure of damages. So even a medical expert who's coming in cannot just base their opinion on amounts billed. So courts get it that these charges are not representative of reality. And that works to your favor when you're fighting a hospital. Tennessee Supreme Court talked about the collateral source rule, which was an evidentiary rule that prohibited omission of evidence that the plaintiff or victim has received compensation from some source other than the damages sought against the defendant. This can come up in cases where medical bills are paid by an insurance company and you're trying to use that as evidence for an amount that should be collected by someone else later. Okay, another Tennessee case, Dedman v. Steelman. Talked about charge master lists being maintained by healthcare providers are not indicative of reasonable value of services. So again, we've got one more court that says these prices are fake. So even if the difference between billed charges and actual charges became known to the jury, the collateral source rule would not be violated because such a price differential are not payments or benefits to the plaintiff. So hospitals have tried to argue for a long time that agreements that they have with Blue Cross Blue Shield are private and shouldn't be required to be disclosed. Several different legislatures have tried to require disclosure and they fought that, and they try and fight it in the courtroom as well. They argue that publishing those rates will put them at a competitive disadvantage because Cigna and Aetna will see what Blue Cross gets. I think this works to your favor because you can require that ultimate disclosure, and it's a reason the hospital wouldn't want to take this into the courtroom because now they get to air their dirty laundry, so to speak, in the form of their charge master list and their actual prices as part of figuring out what fair market value is in front of everybody. Okay. Virginia Supreme Court did take a view that I was disappointed with. In an acute MI scenario, meaning acute myocardial infarction, an adhesion contract could be signed under duress in the emergency room and still be a valid contract, at least in Virginia. While the court can take this into consideration, it's not dispositive in terms of saying that it's invalid. That would still get to go to the jury. Okay, Texas Supreme Court case. Okay. So here, they talked about different procedural rules that are at play in Texas, and I wanted to include this as an example for everyone. So their procedural rules allow broad discovery, which usually works in your patient's advantage. And the subject matter of the underlying action, which involves enforceability of a hospital lien, securing payment of charges for services rendered to an uninsured patient, encompasses the reasonableness of those charges. So here, the trial court's order at issue in this mandamus proceeding requires a defendant hospital to produce information regarding its reimbursement rates from a private insurer and public payers for services it provided to the plaintiff. The hospital argued those rates were irrelevant to whether its charges to the uninsured plaintiff were reasonable, and the trial court therefore abused its discretion in ordering production of the information. We disagree. So this was a case that started at the trial court level and worked its way up in the appellate process, and ultimately the hospital, even though they appealed it to higher levels and got to the Supreme Court, the court system said, no, if you're going to litigate these cases, that information's coming out. You're not going to get to block it under the collateral source rule. Okay, so enough of the legalese here. Again, those are way too many words on those slides, but it's mainly there for your reference later. So now that you have that background, what does a self-pay patient actually, what should they actually expect to pay, and how can they come to that number? So one, you've got the fair market value arguments, and you've got the court system that sort of looks at things on their own. And let's assume that you know what the hospital is going to get if they stay out of court. So let's say you never paid that debt at all. What does that start to look like for the hospital? And here you can see that medical debt owes and payment rates vary quite a bit by category. So hospitals know that the more they're charging you, the less they can expect to receive. And it's literally pennies on the dollar when you get above 10 grand. If it's less than 1,200, you're not as likely to get them to settle for a much lower amount. But as it gets higher, your settlement rates should be dramatically reduced. Because if they sell this for bad debt, which is their alternative to you paying it, is them selling it to a debt collector, and the debt collector trying to get it, they're getting about 3 or 4% of the total amount. So if your patient says to you, hey, I know you told me not to pay this bill right away, that you want to help me sort of figure out fair market value, and you want to figure out what the hospital is probably going to get if they dump this elsewhere. What does this really look like in terms of my credit report in the meantime? This is information worth knowing. So Equifax, Experian, and TransUnion have to wait 180 days before they can add a medical bill to your credit report. And you're allowed to create a dispute over that well within 6 months. And if it's being disputed in the court system, of course, they can't add it to the credit report either. And worst case scenario, if it does get on your credit report, it's only going to hang out there for 7 years. Okay, and it's fairly common, and debt reporting agencies tend to look at this debt differently than other kinds of debt. Note there are probably many other states that do this too, but in California and Massachusetts specifically, you simply cannot bill it to collections during any coverage denial appeal. So that's even before you've taken it to the court system at all. If you happen to be in West Virginia or North Carolina, the hospitals simply are not allowed to do wage garnishments for medical debt. Other considerations, you can go to the media, as I mentioned earlier, especially if it's a nonprofit hospital that's known to do this routinely. They're supposed to have charity policies as part of the Affordable Care Act, and they might be violating those. This could come into play based on your patient's income. There's also something called a federal uncompensated care fund. So in addition to selling this for bad debt, the hospital can go back and seek some reimbursement from the federal government. And then the other key point to take away, as I mentioned earlier, is they get about 4 cents on the dollar for your debt. So if you pay them more than 4 cents on the dollar, they're coming out ahead with you paying them. So if they act like you are messing them over by settling for half of what they're charging, know that that's not true. If you decide to take them to small claims court, your limitations vary quite a bit by state. You'll see some that are quite low. I think Kentucky was the lowest on the list at only $2,500. So if there's more than $2,500 in dispute in Kentucky, then you need to go beyond small claims court into traditional court. But in some other states, you can go much higher. Tennessee, it's as high as $25,000 just across the border. And small claims court, I should say, generally works to your advantage because the fees are lower. And if the patient if you help them do some of this homework, they may well be able to bring the case forward on their own. Hospitals might be the ones not showing up then. Okay, so just an example here. Have an appendectomy, get charged a sticker price of $30,000. You had a $10,000 deductible plan, and you used your high-tech rights, which I've covered in other presentations, but not as much today, which means that you can ask for transparent pricing even if you do have insurance at any point, and you get the sticker bill. What do you do about it? So start referencing Medicare rates, start referencing Medicaid rates, look at what the hospital would get if they sold it to a debt collector, and look at what a private surgery center might charge, such as the Oklahoma City Surgery Center, or one of about 10 or so others that are now listing their prices as well. And then you can walk into court with that information. So remember, hospitals are embarrassed by their own charge masters. They don't want to publish these in court. They're going to try and block it using that collateral source rule, which was the legal headache that I was reading to you earlier. And in several states, you can overcome that. Many states have verdicts already at the Supreme Court level overcoming that. They may not show up in small claims court, especially if you were the one to bring the case forward, before they could try and send it to any debt collector, or before they could try and do any wage garnishments. Okay. Here's some recommended reading. Again, those are two excellent articles by George Nation that go into great detail on this topic. And we're going to move from that into the quick DPC legislative summary here. So 2019, we had lots of state legislators that sort of follow the federal pattern in that the same folks are in the House and Senate at the state level this year that they were last year. And those bills that didn't get action last year from 2019 roll over from 2019 to 2020, but most of them haven't gotten much traction, with the exception of some Medicaid private contracting discussions in Colorado. Colorado and Kentucky are the only two states in the country where you are prohibited from signing a private contract with a Medicaid patient, full stop. For a covered service, you can't sign a private contract. It doesn't matter if you haven't even enrolled in Medicaid in those states. As a physician, you're not allowed to privately contract. And in Colorado, they're making efforts to correct that. Maryland is, I abbreviated that NI, meaning not insurance. They have some not insurance legislation, so they're defining DPC as outside of insurance and attempting to do that this year. Washington, there was a talk about having their DPC practices no longer have to submit annual statements to the insurance commissioner, which was a silly requirement originally. So the abbreviations above, for those keeping track, if it's relevant to your state, NI means not insurance, and the MP stands for Medicaid pilot discussions. Okay, so 2020 federal DPC legislative summary. There were many tax corrective bills at the federal legislature with no real movement on any of them. There were some very late action in the CARES Act, which we're going to discuss a little bit later, about potentially having a Primary Care Enhancement Act language in it, but ultimately that was pulled out last minute by Senator Wyden. So it didn't really matter. It was there briefly and then it was gone. And there was some controversy about that language that we won't get into here. There were expectations that Trump's prior executive orders would have resulted in Treasury actions and changing interpretations about HSA regulations under 213D that would have affected DPC practices. And ultimately, we didn't see anything come of that, at least not yet as far as I've seen. And then there's a civil monetary penalties law final rule that is due later this year. It may well be delayed with all the other things that are going on. I'm not going to get into that into great detail here, but note that that's the main hurdle for DPC physicians right now, that we're looking to do creative things within certain Medicare setups that were closer to mimicking DPC. So civil monetary penalties law prevents you from offering certain services for free to Medicare patients, because when you do that, they view that as an unlawful inducement. So for example, if you charged them a monthly fee and then didn't charge them when they came in on a fee-for-service basis because you wanted to incentivize them to be in some monthly capitated payment program that Medicare was doing, unless you find an exception, which there are now some interesting exceptions, unless you find one of those, it's going to be a civil monetary penalties violation. Okay. So the CARES Act, which recently passed, did have a telehealth change to HSA laws, and it's in section 3701. So people who've seen me talk about direct primary care issues before, there are two big issues that we have discussed ad nauseum for, sounds like close to 10 years, I would think, which is 213D and 223C. And 223C is what we call the gap plan problem, and that's what was addressed a little bit in the CARES Act. So if you have an HSA, in order to continue having it and to fund it and to use it, you have to have a high deductible plan according to the IRS. If you have anything else that's below that high deductible plan that gives you some sort of first dollar coverage for something, then there needs to be an exception for that. Otherwise, they say, by nature of you having the second plan, in our case DPC, you are no longer eligible to continue funding an HSA. So that's the gap plan problem under 223C. And it was not fixed for most DPC practices, but it was fixed for groups like Teladoc and others that lobbied heavily on this. I think Amazon was probably part of that lobbying group. And what they said there was, if the employer or someone else wants to come in and pay for telehealth and pay for it with no copay to the individual, meaning this is a kind of gap plan, then they're not going to screw up your HSA eligibility by reason for failing to have a deductible for telehealth or other remote care services. And I've looked and looked and looked, and I haven't found a definition from them in the CARES Act or any other federal law about what's considered an other remote care service. So to the extent you do DPC and limit that monthly fee to telehealth, you might have an argument for HSA usage within that setup. I'll get into that more in other talks down the road. We're not going to do that in detail today unless people want to do it in the Q&A. So here's where things stand now in terms of states that have not insurance law in the books and have defined DPC as outside of insurance. And at this point, we do have a majority of states that are in that category. And some stragglers will eventually cross the finish line, I think. Okay. And here's the most updated map in terms of physician dispensing regulations. This is all on DPC Frontier. There haven't been any major changes here. I do like to point out that there's an ongoing litigation, thanks to Dr. Held, who's an AAPS member as well, and Michael Garrett in Texas through the Institute for Justice. They are suing the State Board of Pharmacy and State Medical Board for dispensing rights there. And the Institute for Justice is looking for physicians who want to be a part of the same argument in Montana as the next place they're going. And then I imagine they'll pursue the red states in the Northeast after that. So on to COVID-19. So there have been a lot of emergency regulations enacted here, and it's been a game of whack-a-mole to try and stay on top of all of them. And I'm going to try and do it as cleanly as I can. So the first thing to note is that there's an EMTALA pandemic waiver, and EMTALA requires that patients be screened for an emergency condition. And if they have an emergency condition, then the ER has to treat it. The screening doesn't have to take place with a physician. It can be done by a nurse. And so a lot of folks have always interpreted EMTALA as a right to emergency care, and that often is the effect of it. But if the hospital screens you and decides that it's not an emergency, then they don't have to do anything right away. And they were given EMTALA waivers under this emergency declaration, where they can now pretty much decline patients by saying, you know, we're literally too full. And this is part of the reason they're doing a lot of the screenings physically outside the hospital, is to try to reduce the COVID-19 burden literally within the ER itself. There have been a variety of telemedicine security exceptions that were put in place too, where the auditors in charge of HIPAA have discretion over what provisions they're going to enforce. I would point out that you don't need to rush to a non-secure platform to do telemed visits with patients, because you have Doxy.me and many other companies that are similar to that. They're actually free and will sign a business associate agreement with you, a BAA, for you to do this kind of work. The FSMB has been tracking a variety of telemed licensure exceptions that are being put in place by various governors and state medical boards. Some states have gone so far as to say, as long as you have a license in another state and you're not, you know, under current investigation, then you are free to do telemed with our patients from your state. Other states have a streamlined process where they'll charge you a very low fee or no fee at all and get back to you in a matter of days if you just want to do telemed during the crisis. There have been Medicare telemedicine exceptions put in place as well. And the analogy here is that Medicare patients are basically being treated like VA patients or Federal Bureau of Prisons patients, in that if you were seeing exclusively Medicare patients, you can do that in pretty much any state jurisdiction as long as you have a state license somewhere. So people have long known that if you were from Florida and you're moving to Hawaii to work at the VA and you're only going to work at the VA, you can use your Florida medical license to see exclusively VA patients in Florida. Well, now you can do the same thing for exclusively Medicare patients, at least as far as that emergency enactment stays in place. Okay. And I will point out that President Trump made a statement that sort of confused people on that, because he made it sound like that applied to all patients, but of course it doesn't apply to private pay patients, to people that aren't on Medicare, because the federal government doesn't have jurisdiction in that regard. The opt-out rules have changed. Historically, if you had opted out of Medicare, you had 90 days to say, oops, I made a mistake, when you very first opted out. And if you didn't go back on it within that 90-day window, then you had a rolling 2-year window where you could say, okay, I changed my mind, I want to participate in Medicare again. During the crisis, you can raise your hand at any point and go back to participating status by calling a 1-800 number for your local MAC. So when it comes to HIPAA, as I mentioned on the overview slide there is some discretionary enforcement at play. So the HHS Office for Civil Rights will exercise enforcement discretion for uses and disclosures of protected health information by business associates for public health and health oversight activities during the pandemic. So in connection with good faith participation in COVID-19, community-based testing sites, and during the public health emergency. So here they're talking about community testing. Here they're talking about business associates. So this is you quickly changing which attorney, accountant, someone else that you're working with, a BAA, maybe a new software vendor, maybe somebody who usually didn't do software in healthcare now suddenly doing that. So that's the BAA rule. And then the other is the community testing rule to make it easier to get tests done quickly. And of course, you also have the telemedicine discretion, which is what most of us have already heard about and sort of focused on, the fact that you could use non-secure platforms to do telemed visits and expect leeway on that regard. So even Skype and FaceTime and other things like that. So what if you get COVID-19 while you're at work? A lot of us work at hospitals. Hospitals have been out of PPE. Isn't PPE required under OSHA? What about these hospital CEOs that are ripping masks off people and telling them they're using the mask incorrectly, or that you can't bring a mask in from home because not everybody else has it and that's not fair? Isn't that an OSHA violation? Yes. Yes, it is an OSHA violation. But the question is it going to be enforced right now? And unfortunately, the answer to that is usually going to be no. They do have discretion. So there could, and we're going to come to that in a minute, that if you get COVID-19 at work, is that a workers' comp claim? And the answer there seems to be yes. Historically, if you got something like influenza, the answer would be no, but with COVID-19, they're saying yes, it is. And I would generally advise people, if you have the option of going under your insurance, your traditional health insurance, if that's the route you want to go, or workers' comp, always take the workers' comp pathway. It's more likely to be paid, and you're more likely to be able to follow it long term if, say, you wind up with some sort of chronic obstructive pulmonary disease as a result of a long ICU stay. Okay, so there's the work-related definition. This is all kind of reference material for later. Okay, so as I mentioned a moment ago, unfortunately, there is a lot of enforcement discretion when it comes to OSHA rules under the COVID-19 pandemic. Secretary of Labor was directed to, quote, consider all appropriate and necessary steps to increase the availability of respirators. OSHA has specific enforcement discretion for enforcing a variety of standards. And I sort of called this basking in mediocrity. We have these laws to supposedly protect ourselves, and then we only keep them in place when they're convenient. And right now it's not convenient, so we're just going to ignore it. And we burdened everybody with it long term, and now when we need it most to protect our healthcare workers, it's not going to be followed, and it's pretty frustrating. So they speak of this in terms of a hierarchy of controls, and this is explained on the OSHA website. You start by using engineering controls, meaning how you design the entire building and the structure, and then you have administrative controls, and then safe work practices. And these are all defined terms on the OSHA page. To anybody who does a lot of occupational medicine work, you can look into those things. The efforts are prioritized in an order that I found interesting. So first, you're supposed to try to get equipment that was approved by NIOSH. And since you probably can't do that, then tab 2 is that you try to get equipment that's certified in accordance with standards of other countries, such as China, unless you, except China, I'll rephrase. So you go by standards of everybody except China. So we're going to discriminate against China a little bit there. And then if you can't go by other country standards, then you can go by China standards. And if that doesn't work, then you can just make your own masks. And we're going to tell you how to do that. So it's sort of embarrassing hierarchy of where we are right now. So if you have equipment that's in various states of not idealness, shall we say, then they're recommending you first use expired equipment, and then go to reused equipment, and then go to homemade equipment. And all this is there for your reference too. There are some conflicting points of OSHA that I think are worth pointing out. So if you're one of the hospital employees who's really upset about this, that you're using a homemade mask, or that maybe you weren't even allowed to wear that when you wanted to wear it, and you're pointing this out, you do have some whistleblower protections that are at play. So Section 11C of the Occupational Safety and Health Act prohibits employers from retaliating against employees for exercising their rights. And these rights include communicating with management about occupational safety or health matters, and asking questions or expressing concerns about workplace safety. And that's exactly what you would be doing. Unfortunately, the counter to that is that the employer can indeed fire employees that feel unsafe due to COVID-19. So you're using your whistleblower protection on the one hand, but on the other hand, the employer is allowed to say, you can go ahead and go. So an employer would not ordinarily be in violation of 11C by taking action to discipline an employee for refusing to perform a normal job activity because of alleged safety or health hazards. There are other wrinkles that can come into play here too, including the Americans with Disabilities Act, where you might need a different accommodation due to a higher risk. You may have some chronic condition that places you at higher risk for death from COVID-19. That could come into play too. Here's an interesting example out of Sioux Falls, South Dakota. This was covered by the BBC, and I've got the link there at the bottom. So here, employees did allege that there were early requests for personal protective equipment, and these requests were ignored, and that sick workers were incentivized to continue working. And I've got the details for you to sort of look at later, and we'll keep going here. So Tim was a new employee who was going through orientation when he heard about the first case, and after that initial announcement, the company was very quiet. We didn't hear anything more about it. We thought things were good. On April 8th, the South Dakota State Health Department said, there are 80 cases in the plant. And then multiple employees told the BBC that they found out about this from the state health department, that none of this was disclosed by the employer, that their increased risk wasn't disclosed, and that no PPE was being passed out, et cetera. They started a temperature checking station and said, okay, we're going to start screening people. But then if you had an elevated temperature, they went ahead and let you go to work anyway, because everybody's got to eat their bacon. So, and then if you didn't want to go through the temperature screening, they just went ahead and let you in the side door. So all this is kind of frustrating, and obviously shows they weren't following their own process, which is about the worst thing you can do. Smithfield instituted other changes like building cardboard cubicles around lunch table seats to try to create a barrier between workers and staggering shifts. But multiple workers said the photos sent to them confirmed that PPE in the form of beard nets, to wear over their faces was kind of a joke. And as you'll see here, wearing a fenestrated beard net is not really going to do much, and those cubicles aren't even 6 feet apart. So it was not a good situation. Smithfield, by the way, is owned by a Chinese company, which probably should have had all kinds of great data on COVID-19 long before we did. All that is left for OSHA to sort out. And even though they've said that there's going to be an awful lot of discretion, I still think there are going to be a number of fines associated with that situation. And you might see that happen in several other places as we reopen various places, and you sort of have these hotspots that happen from time to time if screening measures weren't in place. Okay, as far as CLIA goes, the CLIA program was unable to approve, sorry, I can't see part of my slide here, unable to approve Section 1113 waiver requests with respect to waivers of the CLIA program requirements. The 1113 waiver authority was only applicable to programs that were authorized under the Social Security Act. So in legalese, this is basically saying, look, because OSHA was put in under the SSA and because some other programs were put in there, we got some discretion, but under CLIA, the one place where it would have been really cool to have a lot more discretion, we don't. So unfortunately, CLIA has been keeping things highly complex since 1988, and that didn't change in spite of COVID-19 when we needed all this testing quickly and we did not have it. That's because this has remained a moderate to high complexity test, and there are a lot of requirements that are in place with that keep it from being used broadly. Okay, so what if you don't have a mask at work? OSHA may or may not be able to help you. It depends on what discretion they allow their enforcers to have and what time of the year that's going to be at play. When this was at its peak in New York a couple weeks ago, I imagine that the OSHA enforcers are going to have a lot more deference to the hospitals than they would now. As I mentioned earlier, consider ADA reasonable accommodations. Those might be of assistance to you or your patients. And if you have a COVID-19 claim and you can put it under workers' comp, that's to your benefit to do it that way rather than traditional insurance. Okay. In the National Labor Relations Act, employees can have the right to participate in group activities that improve the conditions of their employment. So that was pointed out by another law office that I was looking at their commentary in this. So if you can't get anywhere under OSHA or ADA or workers' comp, you can look at those regulations as well to see if they would provide you with a course of action for a hospital that wasn't taking PPE seriously. Okay. If the travel restrictions of the hospital conflict with those of the governors, those are worth pointing out. Okay, rationing care and medical supplies. I think this is probably the most interesting topic of the day for a lot of people because this is constantly in the news right now. Take down a bunch of notes when this is happening to you. So hydroxychloroquine, azithromycin, there are a few other medications that are in that category depending on their state. And I've got an overview piece that I put together based on the AMA's overview piece actually in a minute. But note all the details and save copies of things, because I think as more data comes out here, several governors and several various boards, certain hierarchies within state government are going to be embarrassed, and they're going to pull these things from their websites out of that embarrassment. And you want to be able to save it because timing is important. So what do I mean? Well, let's start with hydroxychloroquine. There have been many mixed messages about this. The same CDC website that encourages patients to take hydroxychloroquine for malaria prophylaxis discourages them to do it for COVID-19 prophylaxis. And these quotes are, it's an obvious contrast. And I think Jeremy and several others at AAPS for having this back and forth. And I I was happy to point it out here. For COVID-19, the FDA says use of hydroxychloroquine outside the hospital setting should, you got to be aware of risks of heart rhythm problems, and close supervision is strongly recommended. And then for malaria patients, they say, oh, it can be prescribed for adults and children of all ages. It can even be taken by pregnant women and nursing mothers. And in fact, the CDC has no limits on the use of hydroxychloroquine for the prevention of malaria. Well, in studies that are ongoing in Minnesota right now, they are using the malaria prophylaxis dose as the exact same dose for COVID-19 prophylaxis. So if it's the same dose, why is it so dangerous in one case and so safe in another? It's a medication that's been around for 70 years. And it's one of the most widely taken medications in history. The American College of Cardiology does have a statement up on it as well, saying that chloroquine and its more contemporary derivative, hydroxychloroquine, which is safer than chloroquine, that's the one we have in the United States. These have remained in clinical use for more than a half century and are effective for malaria, lupus, rheumatoid arthritis, but they can cause mild QT prolongation associated with either agent. And despite these suggestive findings, several 100 million courses of chloroquine have been used worldwide without reports of arrhythmic death under World Health Organization surveillance. So we're telling people who are at high risk of death, depending on what you believe, anywhere from 1% to 5%, if they get COVID-19, especially if they're in an older group, to not take a medication that has been known to be safe for a long, long time and may well be very effective at preventing COVID-19. So I think the risk-benefit calculation is way off, and that as more data comes out, people will be more realistic about this. Because of this wrong risk-benefit calculation, you've had several governors and pharmacy boards take actions that I think are discouraging and sad. And they've been encouraged to take these stances by the AMA and by other various government leaders that seem to be looking at the wrong data. There have been, the AMA, last I looked, had a summary statement going over 28 states that had taken some sort of position on hydroxychloroquine. Presumably the other 22 either haven't said much or the AMA hadn't found it. I haven't had the time to look there myself. The governors were engaged in some form or fashion of an order in 5 states. And then some of those states, there were indirect actions by various boards that are abbreviated there in parentheses. Medical boards have put out statements in 5 states, and then boards of pharmacy in 19, many of those at the encouragement of their governor. So if you start adding all these things up, you may get to more than 28 states here. And that's sometimes because both the Board of Medicine and pharmacy, such as California, commented, and in that case, so did the governor. So some states have done the right thing and put out statements like Alabama, which was pretty simple. The Alabama Board of Pharmacy does not intend to set policy about which drugs you should dispense or about the best decisions for your circumstances, which sounds like, hey, medicine is between the physician and the patient, which is the way it's supposed to be. But then you've got other states that have made mistakes. So I'm going to park it on this slide for a little bit because I think this is one of the more interesting summaries that I've put together. If your state isn't listed, it means that in my review of the summary from the AMA and from various governor, state medical board, board of pharmacy websites, it didn't seem like they were saying anything that, as far as I could tell, affected your ability to prescribe for your patients as you choose. If the state was listed here, then that might have happened in some form or fashion. So most states, you can see the common pattern is that the Board of Pharmacy was the most likely one to be involved, and that the most likely restriction was for a 14-day prescription with no refills for hydroxychloroquine, and that it could not be used for prophylaxis. Meaning, in other words, you had to wait till the patient was diagnosed with COVID-19 before you could prescribe the medication. Several states got more aggressive, and they either reduced that term from 14 days to a shorter time period or a more specific time period, or even in West Virginia's case, an exact number of tablets. And others went so far as to say, not only is this a COVID-19 diagnosis sort of clinically on paper from the physician, we're going to require you to have a positive test. And those I put in red in the diagnostic details column. And that's a major issue because in many states, you literally can't get the test. There are many documented cases of people going to hospitals trying to get tested and told that their symptoms were too mild, and several of those patients went home and ultimately died. So you can't, it's not as easy as going to the store and buying a pregnancy test here. This is something that's complicated, expensive, and the availability is quite scattered. So not only is there rationing of the test, there's rationing of the medication based on rationing of the test in multiple states. Nevada and New York are highlighted in red because they were especially problematic. In Nevada, the governor said nobody can use this medication for COVID-19, period. Didn't even matter if you were hospitalized. And so we're going to jump to that in a second. In New York, the governor took possession of the supply of the medication, from what I was reading, and then said, all right, we're going to use this, but it's only going to be for patients who've been diagnosed with a positive test, and only for 14 days and only under a state-administered trial. So what happened in Nevada after the governor took that action? Fortunately, a group of osteopathic physicians and some DO colleagues of ours said to Governor Sisolak, you're messing up here. His regulation said that
Here's the top search result.
His regulation said that the regulation prohibits the prescribing and dispensing of chloroquine and hydroxychloroquine for a COVID-19 diagnosis, requires an ICD-10 code on the prescriptions for drugs, and limits the prescription amount to a 30-day supply for the drugs. And this is not going to work for us. So they sued. They filed a complaint for emergency declaratory relief, asking the court to declare the Nevada State Board of Pharmacy's March 23rd emergency regulation restricting the use of hydroxychloroquine void and invalid because it either prohibits the enforcement or mandate that the board of, because it void and invalid and either prohibit its enforcement or mandate that the Board of Pharmacy rescind it and amend it. So in plain English, the governor doesn't have the ability to practice medicine and shouldn't be prohibiting patients from being treated for this deadly disease. Even if something is being used on a compassionate use basis or off-label basis, 20% of prescribing right now is already for off-label, and this is a medication that's been safe for 50 plus years. So I don't have an answer as to where that's gone yet. I need to try and follow that. All this is happening very quickly. In New York, the governor's executive order said that no pharmacist shall dispense hydroxychloroquine or chloroquine except when written as prescribed for an FDA-approved indication or as part of the state-approved clinical trial, which is what I mentioned a moment ago. And they don't approve any other experimental or prophylactic use. So, all right, hopefully I made it through in a timely manner. I like to go quickly, and these things are recorded so we can always go back to it later. There's some upcoming events. There's my email. Please feel free to email me any questions you have, and I think we should have hopefully plenty of time left for questions this evening.
Yes, thank you very much, Dr. Eskew. This is Jeremy Snavely here again, and I'll kind of help direct traffic for Q&A. Thank you for that excellent presentation full of so much great information. Really appreciate it. So yeah, we'll go to Q&A now. And again, you can submit a written question by clicking the Q&A button, or if you prefer to ask your question verbally, click the raise hand button. And most of you have already figured that out because we have a lot of good questions already. So we'll go with one of the first ones that was asked, just going back to the beginning here. This doctor asks, help me understand the premise. How did my patient incur a surprise hospital bill, and why am I involved?
So as DPC physicians, we always try to pursue price transparency throughout the system. And we find ourselves in the position of helping patients do that. So to the extent we can navigate things in advance by planning out the appendectomy, or planning out, I guess you don't plan very many appendectomies, but planning out the cholecystectomy, then you do that. And you help them decide when to apply their insurance and when not to, based on their deductible and based on what prices you get for those surgical or diagnostic services or consultation services. But In the emergency setting, you often don't have that option. You hear about the ER visit after the fact, and your frustrated patient might come to you, hopefully, and look for your help in this regard, since you've otherwise been helpful with a lot of things. And I think historically, DPC physicians have said, well, that's sort of after the fact. I'm not an attorney. I don't have any idea what to tell you here. Nobody can afford an attorney, so nobody does much about it. And my goal here is to empower DPC physicians, and so doing that, empower all of our patients to take these actions that don't need to be as intimidating as they are, especially if you can do them in small claims court. So I'm sure that was a little bit heavy on the legalese and a little scattered, but it's meant to be a reference for everyone, hopefully moving forward.
Thank you. And okay, we'll go to a live question here. Let's see, one second. We have a hand raised. It looked like Dr. Wax, you had your hand raised, and now it's not raised anymore. So if you intended to raise it, just, oh, there, yep, you got it again. So we'll go to Dr. Craig Wax. Welcome to the webinar.
Oh, thank you. Thanks for hosting, Jeremy, and thanks to AAPS for putting this on, and thanks to the kind DO and lawyer speaker as well. Thanks for all of your efforts, as always. So what options does a citizen and physician in the state have to legally to sue the governor? You know, I don't know any lawyers that are willing to take on this tyrant we have as a governor in New Jersey who doesn't listen. We have a petition with hundreds of names and dozens of physicians, and he doesn't respond. He doesn't even give us the courtesy of an answer. I've spoken with the president, the head of the New Jersey Senate, the Senate president, if you will, and he has no real play with the governor and can't get him to budge on prescribing of hydroxychloroquine. Because as we all know, I mean, you talk about moral injury, looking at people on a video screen or in person, knowing you might be able to help them, and the governor won't permit it unless you have a positive test. And the test doesn't come positive till 2 to 3 weeks into the game, when the patient is more serious and potentially won't benefit. So what legal what legal options do we have?
I'm not a constitutional lawyer. I focus on contracts and DPC things and administrative law. From my limited experience in that area, I would sort of echo what I think Andy Schlafly sort of focused on a few weeks ago, which is you can use an association to do what the Nevada DOs are doing and to pursue injunctive relief. But whether or not you get it in enough time to make a difference is the big sticking point. And your success or failure is often determined based on who did it and whether or not you have a procedural way to go after their authority to do what they did. So I don't like a lot of things about what's going on, but the thing that bothers me the most is that many state governors are leaning on their boards of pharmacy and boards of medicine to issue veiled threats to physicians and nurse practitioners saying, if you do these things in a way that we don't like, we're going to come after you. And we're going to come after your license for trying to save your patient's life. And that's not fair. And it's not the right way to do it. If we really, let's change the hypothetical slightly. If there were only 10,000 pills of hydroxychloroquine left and every factory that was manufacturing them was so full of COVID-19 that nobody could make the pills, and the governor and or the president and or whoever was going to use their police authority to literally take possession of these things and ration them in some way that made sense to them, I don't like that either. But at least they're the one doing the rationing. They shouldn't be asking us physicians to do their rationing for them and hiding it sort of from the patients by saying that the medication is more dangerous on one part of their webpage than part of the other. So I guess I don't have a great answer for you. I would use an association local to New Jersey, and depending on which entity is engaged in this threat on physician autonomy, that's how I would go after them procedurally and try to get somewhere with injunctive relief like what they're doing in Nevada.
All right, thank you. Thanks. So.
Huh?
Okay, thank you for that, Dr. Wax. And so let's see, another interesting question we got is, can a hospital demand a patient turn over their credit report? Or sorry, can a hospital demand a patient turn over their tax return in return for, if the patient's trying to get their bill reduced or trying to get a fair price, can the hospital demand a tax return? This one doctor has, I guess, run across that where the hospital says, okay, well, maybe we'll lower the price, but we want to see the patient's tax return first.
You could use the tax return as evidence that the patient is in a certain category where they would be maybe subject to the hospital's own internal policies under the ACA.
Oops.
About not favorable to your patient and the patient doesn't want to turn it over, then they should fight that procedurally to the extent they can. I don't know that the answer there might vary based on local evidence rules.
Yeah.
But it's kind of the counterplay to the hospital not wanting to tell you how much Blue Cross Blue Shield pays them for that given procedure, and you're able to force them to do that. They might be able to, if in part of your argument to the hospital you make the argument that you literally cannot afford it and that you're in a category that should be afforded charity care, then I think that's fair game. If none of your argument was based on your ability to afford it, but based instead on other notions of free market medicine and price transparency, then I think their ability to get that document would be more limited.
Yeah, thank you for the question. Thank you, Dr. Eskew. One thing that I found on this was the California has a Hospital Fair Pricing Act, and where patients who are under 300% of the poverty level or over 300, up to 300% of the poverty level can qualify for reduced pricing at hospitals in California. And written into the regulations, the hospital can ask for a tax return from those patients. So that, maybe it does vary by state. California actually has something specifically about that. Okay, let's see. So yeah, let me move my Q&A box over here. Yep. Please click the raise your hand button if you'd like to raise your hand and ask a question verbally. If you're on the phone, you can ask the question, and you'd like to ask a question verbally, hit *9, and *9 will virtually raise your hand so that I'll see you'd like to ask a question. And while I'm waiting for a hand to pop up there's some other good questions in the Q&A box. One is, what about the Burton Act and related to hospitals being required to lower their price or provide charity care? I Googled that. I looked that up here while you were talking, so I have some feedback on that. But Dr. Eskew, I'll give you a crack at that if you wanted to try that one.
Well, I'm not an expert on the Hill-Burton. It's been around since the 40s, I think, and there are provisions in there for requiring hospitals to do free and reduced care under certain circumstances, and I believe that was modified and maybe even made more aggressive by some of the ACA requirements, and that's where you get to go after hospitals for the sort of fiction of their nonprofit status and point out how they're not playing by their own rules.
Yeah, thank you, Dr. Eskew. Yeah, so apparently there's 140 healthcare facilities that still fall under that law. Not every hospital does, but there are 140 that do. And if you want some more information on that, just email me afterwards and I'll send you what the research I found on the Hill-Burton Act and what it requires and who it impacts. Okay, thank you. So let's see, we have some hands raised here, and we will go to Dr. Thomas. Dr. Thomas, welcome to the webinar. Thanks for joining us.
Perfect. Thank you. I'm trying to go back to my chat here to look at this, to ask a couple questions. Okay, financially responsible. Can we hold the governors or pharmacy boards somehow financially responsible or legally responsible, or even Fauci and the FDA financially or legally responsible for our patient deaths, patient harm?
The government often gives itself immunity, and unless you can find a way to get around that immunity, the answer is usually going to be no. There are one of the most common ways at the federal level is to make what's called a 1983 claim, and I'm not an expert on those kinds of things, but they're tough cases to make, and I don't think, if for example, you had Fauci or somebody else who was negative on a medication that ultimately worked and positive on one that wasn't, I don't think you're going to get much from the federal government in terms of that issue. I do think that if you have a letter, certainly if you're in Nevada or New York, and you have a letter in your hand from the governor that sort of explains their missteps in this regard, and you want to prescribe it, I would document that in your own chart. I would put the letter in the chart. I would give a copy of both of those to the patient, and I would tell them exactly who to call and complain, and make it crystal clear all over the record that you wanted to do something you weren't allowed to do, to build your case later. But I'm not a procedural expert on how to bring that case eventually. My biggest takeaway for everybody now was to save all these things, save the evidence so that you can defend yourself and your patients down the road when there are probably going to be some sort of pathways that are built. And are there going to be millions and millions in damages? I don't think so, because the government's not going to have that money to pay out. But one day this is going to get easier, and when it does, we want it to be really clear who was doing the rationing here, that it wasn't the physicians, that the physicians were being threatened, and we need to make that clear to our patients.
Thank you very much. And that goes to the next part of the question. The distributors have enough supply and they seem to be distributing it preferably to the large hospitals, neglecting the small hospitals, neglecting the independent pharmacies. To a certain extent, when Trump spoke up against it in late March, early April, there was some more distribution to the independent pharmacies and things. But this is not a problem with scarcity. And is there any way to get a heat map of where the hydroxychloroquine is, exactly how much there is around the state, in order to perhaps convince the governors and the pharmacy board that there's no need to ration it?
That's a great question. I wish I had that heat map. I know maybe 5 or 6 weeks ago, I can't remember how long ago it was, but there was this expectation that several 100 million tablets could be cranked out in a few weeks. I know that a lot of that was domestically. We were trying to get some supply from India, but I think even Mylan Pharmaceuticals in Morgantown, West Virginia was one that I was familiar with that was supposedly able to make a lot of this medication very quickly. So yes, I think that's worth pursuing. I don't know who would have that data. But if you could demonstrate that the stockpile had 500 million tablets in it at this point, then the argument that it needs to be rationed certainly fades away quickly.
Thank you for those excellent questions, and thank you, Dr. Eskew. Okay, let's switch back to a written question here about hospital bills. This participant asks, what form should a patient sign or not sign when they end up at the ER? Should they write any comments on the forms about not having read the forms, or have them explain to their satisfaction?
Well, the hypothetical, when you're getting, I guess there are two scenarios here. One is an emergency scenario, which is the main one I was focused on, and the other is the non-emergent. So if it's an emergency, you may well roll in there on a gurney unconscious, and of course nothing is signed at all. If it's an emergency where you have a whole lot of pain or a lot of chest pain and you're barely awake, then what you sign really doesn't matter. If you're awake enough to write something on the form, even though it is an emergency, I would write something like, this is an adhesion agreement at the top. And then at the bottom where I'm signing it, I would say, I'm demanding Medicare, Medicaid, whatever you want to write on there, rates. Or if you're going to If you're an insured patient, you could invoke your high-tech rights. That'd be kind of bold to do in an emergency, so I'm not recommending that. But you have all those options available to you if you're awake enough to try to push them through. I think writing those things on the form are wise, but they're not required in order to litigate these things after the fact. Everything I pointed out there about being under duress, about it being an adhesion agreement, about it being unconscionable in its terms, all those things apply and can be, those rights to you in court are preserved even if you simply sign the form. So in an emergency situation. If it's not an emergency, then the court's going to view it a little differently because one, there's no duress. So there went that argument. The adhesion agreement is still possible and the unconscionability agreement is still possible, but the court's more likely to want you to have done some homework and to not agree to sort of any price up front, which is what most of them say right now. And that's part of your unconscionability argument. So if it's not an emergency, I am most certainly telling you, yes, try to come to an agreement with them up front. And if they're not going to do that and they're going to demand that you sign this, that, or the other form, then you definitely need to be making edits to that form and asking that they sign it as well, so that you've had a back and forth and you've had a chance to sort of protect yourself from getting this fake sticker price and giving them the argument that you promised to pay that price.
Thank you. Good question, and thank you for the answer. So just a follow-up to that in the Q&A box here is what is a proper venue for small claims in these scenarios, where the hospital or where the patient is located? I guess in many cases those might be the same, but in some cases they wouldn't be.
Right. So the nice thing about being a plaintiff in general, including small claims court, is that you get to decide where the venue is. So if you wait on the hospital to try to sue you and garnish your wages, they're going to pick whatever court's closest to them in whatever format they want. And if you're the one to bring it against the hospital, then you're the one picking your local small claims court and asking them to come to you. And they can try to move it, but the chance of them moving a small claims case, I think, is pretty low.
Thank you. Thank you. Lots of great questions here. Thank you, everyone. So we're going to go to a caller again here, and this is a caller with area code 713. Caller from 713, please go ahead.
Yeah, hi, this is Dr. Emmanuel. I'm calling from Texas. I was not able to get on the video, so I don't know what the rules are in Texas, whether I could still prescribe hydroxychloroquine, and whether I could be threatened or whether they could come after my license. I kind of came in late. Then I'll ask the question. I'll ask the question that I wanted to ask. Okay. So what's the deal in Texas? If you can just please, I'm sorry for taking you back a little bit.
Mm-hmm. So hopefully you'll get access to it after the fact, but it was on one of my slides. Texas did have some comments on this, and it was out of their board of pharmacy, and they were the most common sort of problematic scenario in that you do have to have a COVID-19 diagnosis. It doesn't have to be confirmed with a lab, but they have to have a diagnosis. You're not allowed to prescribe any refills. You're not allowed to use it for prophylaxis, and you're limited to a 14-day supply of the medication.
Okay. We know that already. So question, there's a 2005 study that was done on the Institute of Virology that was actually published about hydroxychloroquine used with COVID. I think it was SARS at that time. And it was actually published under Dr. Fauci. So basically, Dr. Fauci has this information. If we cannot sue him because he's the government, can they make a complaint against him because he's a physician? Even though he's part of the government, but he's also a physician, and what he's doing is unethical. Is there some kind of, because like if doctors, is there some way that doctors can, is there some kind of course of action we can take to stop what Fauci is doing? That's what I'm trying to say. Because he's a physician too, and he knows that what she's doing is unethical, and people are dying because of what he's doing.
Well, that's a difficult question. In general, physicians are able to report other physicians to the state medical board for doing any number of things that we view as unethical. So theoretically, you could do that in any circumstance, including this one. I think the medical board's likely to view that as a political commentary and obviously would be dismissed pretty quickly. This is something that's going to be litigated in the court of public opinion, if you will, like most politics. And the frustrating part is we have to watch a lot of patients suffer in the interim when we feel like we could have done something about it. So I guess I'm going to disappoint you that I don't know an immediate way to do anything about that. Other than, you know, if you speak the truth often enough, eventually people will find it. I think you mentioned that 2005 study. That's one of many that Dr. Robb and others at AAPS have done an excellent job of collating, and there's an AAPS webpage around COVID-19 that has a lot of that data aggregated. And we've had several different groups sharing that data. And the more people look at it, I think the more likely those in the government that are opposed to this for whatever reason will back up and let physicians and patients, you know, practice medicine.
Yeah, thank you both very much. And all right, so we'll shift gears here slightly. This is a question, and Dr. Emmons, I see, addressed this in the chat room as well. This doctor asked, do you know what the typical path is for medical malpractice coverage for doctors who volunteer for the Medical Reserve Corps through their local public health department during a time of public health emergency such as this? Is the Federal Tort Claims Act an option? Interesting question. Thank you for asking that. Any feedback to that one, Dr. Eskew?
Please email me that question,
Yeah.
and I can look into it
So,
and be very specific in my response. But I think you're correct. I think the Federal Tort Claims Act should apply in those situations.
yeah. So Dr. Emmons in the chat, thank you. Dr. Emmons in the chat room says he asked his state, he asked his governor about that question, or he asked the state of Vermont, and the governor's office refused to answer him. Thanks for sharing that, Dr. Emmons.
So different states, I will say, if you don't want to go on the Federal Tort Claims Act, there are different states that do have similar laws that sometimes will give you coverage at the state level too, based on volunteering your time and that kind of thing.
Thank you. All right, we're going to go to a caller here, Dr. Ritz. Dr. Ritz, thanks for being with us tonight.
Thank you. I enjoy the discussion very much. I'd like to find out what you mentioned, the KETOM legislation or KETOM laws under the First Amendment, that the individual has the right to petition the government for redress of grievances. Can you comment or expand on that? Because some states have watered that down to where it's very narrow that you can file a KETOM.
Well, as far as I know, the states don't have much jurisdiction over this particular piece. They may have their own different KETOM laws on the side, but it's a federal law, and there used to be lots of different federal laws that had KETOM provisions in them, but this is one of the few that has stayed in place over the years. So I did have a couple slides as a reference on that. I'll go back to those and sort of look at them in a little bit more detail, but so if you're going to file a False Claims Act case, you can file it against any person who knowingly presents a false claim for payment or approval, knowingly makes a false record statement that is material to the fraudulent claim, and if you can prove those things, then they are liable to the federal government for a civil penalty of not less than $10,957 and not more than $21,916. That's per claim, okay? Even if the claim was for 20 bucks, plus 3 times the amount of damages the government sustains from the actions of that person. So that's where you would multiply in my first simple analogy, your example, you'd multiply the 20 by 3 and get 60 bucks. So you could maybe theoretically have just under $11,000 in damages for a $20 claim. And if the claim had been for 10 grand, then you'd have a very different calculation where it's 40 grand. The reason I brought that up here was if you can show that on your particular patient's bill that they were doing something that was knowingly fraudulent, then you've got this case against them. And $40,000 in one small False Claims Act case is a nice, I guess, poke in the eye against the hospital, and it's a way for your patient to get back at them. But where it really gets interesting is if you get the sense that this didn't just happen to your patient, but it's happened to 5 of your patients, and you think it's a systemic problem that the hospital's routinely screwing up this particular item over and over and over, then that becomes $1 million case and your patient gets to retire to Hawaii.
Thank you. Thank you for that question, and thank you for that answer. Okay, let's see. We have a lot of great questions here. So here is one that kind of goes back, shifting gears again, that goes back to your point, your slide about Colorado, the unique situation in Colorado where DPC doctors cannot accept Medicaid patients into their panels. And this doctor asks what if an employer pays the fee on behalf of their patient who happens to be Medicaid eligible in Colorado? That's an interesting wrinkle on that. Can an employer pay for an employee to have DPC in Colorado if that employee is Medicaid eligible? Wow.
Very good question. I suppose Colorado would probably tell you that if the patient has Medicaid, they're not allowed to privately contract for covered services, because that's, literally the way they interpret it. And it doesn't matter if their employer or their grandma or somebody else is going to pay that fee for them, they still don't allow it. So I'm not sure how difficult it is to be on Medicaid in Colorado, and how often you would have somebody with an employer who's trying to cover DPC when they're on Medicaid. I have no idea how they'd handle that. I think if you want to be aggressive and go ahead and treat those patients, I think the chance of the state of Colorado trying to attack you for offering patients affordable health care like that is very low, and the chance that they would win the case is probably even lower based on a state constitutional law argument, but I'm speculating there. I think and that goes for Colorado or Kentucky. Nobody, to my knowledge, has challenged the constitutionality of these laws in the first place, that you're going to prohibit a patient from privately contracting on their own.
Okay, to all the participants, when you see my face pop back up on the screen, it means that we've reached the end of our scheduled time. I want to thank Dr. Eskew very much for his very informative and wide-ranging conversation. The slides will be available. As Dr. Eskew has mentioned, he wants to give us a toolkit to use with our patients, so there's lots of great information in there. Thank you to all the participants. The webinar series has been very well attended so far, and as I've said before, we want to keep this going far forward into the future, even when the current crisis passes. Dr. Eskew has generously made himself available to answer questions individually, since we're reaching the end of our time and there are still a few questions in the queue. As usual at our AAPS meetings, that we always have great questions. Jeremy, why don't you pick one last question to wrap up with, and then we'll apologize to the people who are still in the queue and give them a chance to communicate with Dr. Eskew individually.
Okay. Yes. Yeah, absolutely. Thank you. Yeah, we'll pick one more here, and we'll go with this one. Yeah. So this doctor writes, we have a lot of low income and underinsured patients. One thing we would like to work on is a handout for our patients that helped list some of their patient rights, as it were, to help them navigate their options when facing high medical bills. However, we aren't attorneys, and we are worried about presenting information to patients because of potential liability. Is potential liability for trying to help patients understand their rights a concern? I guess, so in other words, could a patient come back to the doctor and say, you gave us bad advice and now we're going to hold you accountable for it?
Well, hypothetically, yes, but if you do this wisely, then that shouldn't be the case. I mean, anytime you go into any number of healthcare facilities, they might hand you a HIPAA form that says know your rights, and then they conveniently leave out the high-tech piece, which I think is the most important part of your HIPAA rights. But having that stuff available as a handout on your website, or simply linking to it if AAPS puts it up, or if there's something you like that's similar on DPC Frontier or some other site, go for it. That kind of thing is fine. I think the place DPC docs are most likely to get in trouble is when they start offering tax advice and start clearly saying certain things are usable for HSAs that are not. But something like this, where you're simply handing out a resource that clearly says it's just a free handout, you could put a little disclaimer at the bottom saying this is not legal advice, that kind of thing, you should be fine.
Thank you, Dr. Eskew. Yeah, there are still a few great questions in the queue here. Please, when you get our post-event email, respond with your question and we'll make sure you get an answer, okay? Thank you. Dr. Emmons, did you have any final words you wanted to say to everyone?
Our next webinar will be at the same time in 2 weeks on May 14th. Dr. Dobkin will be presenting on topics on medical ethics that relate to the current pandemic and the public health response to it. We'll hope to see you there. We are launching this series of small discussion groups, and there's still openings if you'd like to join a small discussion group. When you get the feedback form, there's a place on the form where you can indicate your interest in that. Thank you, Dr. Eskew, for a great detailed presentation with lots of good information. The direct primary care model, I think, is a great example of a medical practice model that's really resilient, and it's proving its resilience in this lockdown time. And thanks as always to Jeremy for his superb work in getting the webinar organized and helping with the logistical support.
Yeah, okay, thank you, Dr. Emmons, for your leadership. And Dr. Eskew, thank you so very much for spending the time with us tonight and your invaluable information you shared. Let's see, I just have a couple very quick closing slides here that just to give you a heads up on what's gonna happen after the webinar. So afterwards, here, let me click over here. You're going to get a post of an email, as I said. There'll be a link in the email to take the evaluation. To get CME credit for this, we have to have you fill out that. That's how we will know you attended and that you qualify for credit. Now, we're making it a little bit easier this time to get your CME certificate. We're putting a link in the email where you can download the certificate. But please, you have to also do the evaluation in order to actually qualify for the credit. And so look for that. You'll get that in about 30 minutes from us. And I just need to put a plug in here to Dr. Eskew. You updated your slides with some new information than the version I have. So if you could shoot your slide deck over to me so I can put it in the email, I'd appreciate that.
Okay.
And so with that, I think we'll call it an evening here. Thank you all for joining us. Keep an eye on your email inbox, both for the post-event email and for information about our next webinar. So with that, on behalf of AAPS, good night.